director of the Yale-Mayo Clinic CERSI. Our CERSI is one of four, as I'm sure many of you at the FDA are familiar, and ours is co-located at Yale and the Mayo Clinic. We are very pleased to have joining us today for this lecture on behalf of our CERSI long COVID, doctors Erica Spatz and Kelli O'Laughlin. Dr. Spatz is a cardiologist and associate professor in the Section of Cardiovascular Medicine at Yale and the School of Epidemiology, in the Section of Epidemiology, the School of Public Health. She is also the director of the Preventive Cardiovascular Health Program at Yale, and her research focuses on developing individualized approaches to preventing and treating heart disease. She is part of the long COVID recovery team at Yale, seeing hundreds of patients with long COVID, and is a site PI on the CDC grant entitled Inspire, about which she and Dr. O'Laughlin are going to just talk about today. Dr. Kelli O'Laughlin is an assistant professor in the Departments of Emergency Medicine and Global Health at the University of Washington. She attended Oregon Health and Sciences University School of Medicine, completed her emergency medicine training at UCLA, and earned her MPH at Harvard. She is a clinical research scientist with a focus on global population health. And thank you to them both for agreeing to present today to talk about long COVID, risk factors, symptomatology, and patient-reported outcomes captured through a novel digital health platform. I think there's going to be a lot to learn today, and we're really excited to hear. I know Jessica Ritchie, on behalf of the Yale-Mayo Clinic CERSI, is going to be sharing her screen and steering the slides. Kelli and Erica, I don't know who's going first, but I'm going to hand it off to you and put myself on mute.
Great. Hi, Joe, and hi, everyone from FDA. Thank you so much for having us. As you know, this is an evolving science, and we're excited to share with you some of our knowledge and work to date, but also look forward to questions and ideas and feedback as we continue to learn together in this very open space. So today I'm going to be, Kelli and I will both be presenting. If you'll go to the next slide.
Sure, and Dr. Spatz, I just want to make sure you're able, is this slide taking up the entire screen?
For me, it's not.
Okay.
I'm seeing like presenter mode, and you could put it into, that works, yes.
That's better, great, okay.
Terrific, okay, great. So I'll be presenting some of the background on long COVID, and then Kelli will tell you more about the Inspire study and our enrollment data to date. And then I'll just kind of circle back and talk about clinically a little bit what we're seeing and how we think that the research and the clinical care can inform one another moving forward. Okay, you could go to the next slide. So we know from mostly the amazing reporting by some of our premier newspapers and audio forms that many people with long COVID are young. This is sort of a second epidemic hitting people who are around the ages of 35 to 50 years old, and many of whom have no underlying health conditions. This sort of second stage of COVID has impacted many people who only had mild symptoms with SARS-CoV-2 and were not hospitalized, and we're not finding evidence of organ injury. So what is long COVID? Next slide. Well, for a long time, we were hearing mostly about the stories of people who were not recovering from their acute COVID infection. And this was mostly put out, again, by the lay press, talking about people who were unable to return to work, who were struggling with chronic symptoms, who were going from doctor to doctor to doctor, who were unable to find a diagnosis for their symptoms. And in response to this, many health centers, university, academic medical centers set up long COVID clinics. You know, initially we were designing this for people who were coming out of the hospital. We were anticipating some of the long-term effects of post-ICU syndrome or continued organ dysfunction following severe COVID infection. But very quickly, these stories from the media started presenting within our clinics, again, of these young people mild infection having long-term symptoms and really unable to resume their normal quality of life, their normal functioning. Next slide. So the National Institute of Health ended up terming this PASC, which stands for post-acute sequelae of coronavirus, but it's also been known as long COVID as well as long haul COVID, and there's a few other terms that are also used. The CDC has a new definition that defines this as new, returning, or persistent symptoms following acute SARS-CoV-2 lasting more than 4 weeks. In the UK, the NICE definition, it qualifies this as symptoms that are persisting for more than 12 weeks and that don't have an alternative diagnosis. Some of the most common symptoms that define long haul COVID are fatigue, post-exertional malaise. So a person either does some bit of activity or exercises and they feel decently well with that, but then the next 2 days they sort of crash. We also know a lot about brain fog as a key feature of this syndrome. There's a lot of sleep disturbance, dyspnea or shortness of breath, tachycardia, feeling like the heart is racing, palpitations, as well as chest pain, and many, many other symptoms affecting nearly every organ system, including dermatological, psychiatric, rheumatologic, and so on. Next slide. Much of what we're doing in the post-COVID clinics goes to ruling out organ disease that relates to pulmonary diseases following acute COVID, rheumatologic diseases, neurologic and psychiatric diseases, as well as cardiovascular diseases. Again, other specialties are involved, but primarily, at least our post-COVID clinic and many other sites throughout the country are really centralizing around these 4 specialties as taking on the bulk of patients, given where the predominance of symptoms lie. In the space of cardiovascular disease, for example, when I see a patient, I'm thoughtful and mindful about ruling out cardiovascular diseases that we know have a relationship to COVID, like myocarditis and ischemia and arrhythmia and cardiomyopathy. But oftentimes I'm not finding a diagnosis. And instead I'm finding some dysregulation, disruption to the inflammation system, the immune system, the autoimmune system, and the metabolic system. And these are sort of presenting as something of what we know from ME/CFS, which is myalgic encephalomyopathic chronic fatigue syndrome. It sometimes looks like POTS, which is postural orthostatic tachycardia syndrome. It sometimes looks like endothelial dysfunction, an inability to use oxygen appropriately, sometimes in the lungs, but sometimes also in the muscles. And then again, this heterogeneous syndrome called PASC that really needs to be further phenotyped. Next slide. The true incidence of PASC is unknown, but studies suggest that it is as high as 10 to 30% of adults who have been infected with COVID may go on to develop PASC. Next slide. I'd like to take you through 3 studies just to give you some representation of how this prevalence and some of what we know about PASC has come forward, and speak a little bit about the limitations in the studies that have been conducted so far and which we're trying to address with INSPIRE. One of the big studies was the REACT-2 study. This comes out of the UK, and this is a prospective study of people who test positive for COVID. And in this study, they're using a mobile health app to document symptoms during COVID, as well as in the aftermath of COVID months later. In the UK, they've enrolled over 500,000 residents, which is pretty impressive. And at more than 12 weeks, about a third self-report at least one persisting symptom of COVID, and about 15% report 3 or more symptoms. Now, this study is prone to, it has limitations. Again, there's selection bias about who can participate in a mobile health app survey, who chooses to participate, but those are at least where some of the prevalence rates come from. Next slide. Another study that got a lot of attention is the Swedish healthcare study, which came out in JAMA. This is a study following healthcare workers. It was a prospective study, and they were doing serologic testing as part of their COVID-19 biomarker and immunology study. And in their testing of over 2,000 people, they identified 323 who were positive for COVID, and then they compared them with people who remained COVID negative. They excluded people who had severe COVID and were critically ill in the hospital, and they excluded people who were negative who then subsequently became positive. The mean age in this study was 45, and about 85% were women, 25% had a chronic illness. But when they compared the seropositive to seronegative participants, this was great because they did have a control group. They found that 26% of seropositive had at least one moderate to severe symptom, as compared with 9% in the seronegative group, and that one moderate to severe symptom lasted for at least 2 months. And then 15% versus 3% reported at least one moderate to severe symptom lasting at least 8 months. Some of the more common symptoms reported in this study were anosmia, fatigue, ageusia, as well as dyspnea. So that's loss of smell and taste, fatigue, and shortness of breath. Next slide. This is a study that really deserves a lot of credit. This is from a self-formed group called Patient-Led Research. This is a real testament to citizen science. This group extended from a group called Body Politic. They had an active Facebook page, and they recruited over 3,700 people who were having persistent symptoms following a COVID infection. You can see that primarily people who responded to these surveys were from the US, but there was representation from other countries as well as other ethnicities. Still, most of the people who responded were women. Most were white women, and most were between the ages of 30 and 60. Next slide. These are some of the types of cardiovascular symptoms that were seen, and you can see that like palpitations were up to about 90%. Tachycardia also pretty high, and you can see some of the other cardiovascular symptoms that that's how they defined cardiovascular symptoms. Next slide. They divided their groups into those who have post-exertional malaise versus those who do not. That's in the orange versus the green. And you can see that those who have post-exertional malaise had a range of other symptoms, again, affecting lots of other organ systems. And those who didn't have that feature tended to have fewer additional symptoms. And those who had no, the green is those who had no post-exertional malaise at 6 months. And then those who had no post-exertional malaise at any point also had fewer symptoms than those who had persisting malaise. So these are just ways of phenotyping that they were looking to see if we could identify different patterns that may tell different stories. Next slide. They also did a clustering analysis. I'm not going to go into this, but looking at the trajectory of symptoms over time and whether that helped to explain the preponderance of different symptoms that people experienced. Pretty cool stuff that they did. I give them a lot of credit. It really helps us to characterize the heterogeneity of PASC, but still we're left with important questions around mechanisms and around best diagnostic and treatment approaches. It's also somewhat limited because, again, of the sample, there is selection bias in who responds to this Facebook survey and is reporting out symptoms so long after their COVID infection. Next slide. So we think that better, more robust prospective data could help us to better understand the longevity of long COVID, the trajectory of symptoms, the predictors of full recovery versus persistent symptoms. What does healthcare utilization look like? How do we monitor patient-reported and clinical outcomes? Do they match up? And what is the total impact on physical, mental, and social well-being? And this has really informed our study called INSPIRE. Next slide. So at this point, let me turn it over to Kelli to continue telling you about INSPIRE.
Thank you, Erica. Next slide. So with funding from the Centers for Disease Control and Prevention, Dr. Spatz and I have had this great experience of participating in the INSPIRE study. INSPIRE stands for Innovative Support for Patients with SARS-CoV-2 Infection Registry. So we're going to tell you all about what our goals are with it and what it really looks like to go through this study. Next slide, please. As an overview, it's a longitudinal cohort study that focuses on defining the risk factors. Both clinical and patient-reported outcomes are involved. And we have both people infected with COVID-19, as well as a control group of people who were under investigation but tested negative. Next slide, please. So really, our intention is to compare the disease course among people with symptoms that could be consistent with COVID-19 infection, including those who tested positive and negative. And specific outcomes are patient-reported, self-reported symptoms, and some specific assessments using patient-reported outcomes of cognition, as well as a look at generic health. And we'll tell you more about how we're going to go about looking at those outcomes. Next slide. To point out also that we have some specific things that we want to look at, and one of these is myalgic encephalomyelitis chronic fatigue syndrome. As Dr. Spatz pointed out, there is some overlap in some of the symptoms, and specifically with the people who are having chronic symptoms. And so we will be looking at the risk for ME/CSF in adults who present with symptoms of SARS-CoV-2 infection, comparing both negative and positive diagnoses. Next slide. So an overview for you about our study design. One unique aspect of the INSPIRE study is that it is entirely remote. And we do this by using different modalities, including phone, email, text. It's a prospective observational cohort study, and it does involve people who initially presented with symptoms that may be consistent with SARS-CoV-2. That said, we're enrolling both cases and controls, so people who are testing positive and negative. And those are our target enrollment numbers, 3,600 and 1,200 controls. And the consent and the data collection is all remote through a platform called Hugo Health. This is a study built in with 18 months of longitudinal follow-up. It is multi-center in 8 regions, and the main outcomes are both patient-reported as well as digital health data. Next slide. So an overview of where the study sites are. We have 3 core sites. University of Washington is the clinical core, Rush University is the administrative core, and Yale University is the data and analytic core. I will point out that those 3 core sites are also 3 of the 8 enrolling sites. But in addition to those 3 sites, we have Thomas Jefferson University, UCLA, UCSF, UT Houston, and UT Southwestern. Next slide. So the unique aspect of this study is that it is built on the Hugo Health platform. And Hugo Health is a digital platform, really with a lot of capabilities, of which INSPIRE is using some. So Hugo Health is a platform that enables individuals to share their data. This data could be from their electronic health record. It could be something pushed to them, like a survey. They can also link specific health portals, including pharmacies, devices, wearables, and implants. What Hugo Health offers is an opportunity to collect the data, harmonize it, display it potentially for both the participant as well as for the researcher. And so it's basically an online digital portal that allows for the opportunity to do all of this. Next slide. And the way that we're using Hugo Health for INSPIRE is to help with data maintenance, ensuring accuracy, security, to allow for monitoring and analysis. But most importantly for this study is that it is a way that we can use it for collecting both patient-reported outcomes as well as mediated data collection through the digital health portal. And we'll tell you more about that. Next slide. As far as how the workflow goes, particularly, through the eyes and the perspective of the participant. So basically, the participant accesses Hugo Health via a website link. And this can be on a computer or a smartphone or a tablet, but anything that can access the internet. And one aspect that's unique is that we're able to customize that access for each of the enrolling sites to make it a little bit more personal for each individual to their region with logos that they're familiar with. On those sites, the participants take screening questions to confirm that they're eligible. That site allows an area where they can share their proof of COVID-19 testing. Additionally, they use the Hugo Health site to literally link their digital health portal and to give permission for us to use this for research. And then Hugo Health helps by pushing surveys both at baseline and every 3 months so that we can collect patient-reported outcomes. In terms of the digital personal health record data that is collected through Hugo Health, that's authorized by the participant at the study outset. And there's nothing additional that the participant needs to do to help with that data be pushed. Next slide. An example of some of the digital health data that we're interested in collecting and that is available through electronic health records that are linked to Hugo Health. Emergency medicine, inpatient and outpatient visits. Those records sometimes collect data on current health, current medications, dates of appointments and visits, tests ordered and the results of those tests, notes from healthcare providers, problems listed, diagnoses, vitals, demographic information, immunizations, images and results of images, procedures and outcomes of procedures. And in addition, portals with pharmacy and laboratory data can add additional information about medications as well as laboratory tests and results of those tests. Next slide. So to participate in Inspire, participants must be fluent in either English or Spanish. They are adults 18 years of age or older. They have to have had self-reported symptoms that may have been SARS-CoV-2 that led to their testing, and that had to be within the last 42 days. So they had to be under investigation for SARS-CoV-2, meaning a patient getting screening or diagnostic testing to detect the presence of SARS-CoV-2, including any FDA-approved or authorized molecular or antigen-based assay. And again, that's within 42 days from enrollment. Any qualifying test within 40 days is acceptable. In some instances where people have multiple tests, preference is given to the earliest test available within that window. Next slide. We do have some important exclusion criteria to note. Participants that are interested in participating but that are unable to provide informed consent are not able to participate. If our study team cannot confirm the result of the diagnostic test for SARS-CoV-2, that also is an exclusion criteria. They are not able to participate if they do not have a handheld device or computer or something that allows them to access the internet for participation. Unfortunately, prisoners are also not able to participate. And finally, for individuals who are diagnosed with COVID-19 prior to the 42 days during which they're being screened, they're also not eligible. Next slide. So we have a variety of recruiting and screening methods we use, and these vary a bit by site. And part of that is based on local policies as well as ethic review board requirements. So recruitment happens at some sites based on partnerships with community leaders, at some sites through electronic medical record review and direct contact by the team, digital advertising, recruitment from ambulatory care settings, including testing sites, sometimes recruitment in the inpatient hospital setting. Some teams are using phone-based interactions with talking points. And there are non and minimal contact recruitment and enrollment materials used at many sites during the pandemic. Next slide, please. So as an overview, once people are interested in participating, they're brought to the Hugo Health COVID Inspire website, and they're taken through a list of screening questions that basically goes through the eligibility criteria in a way that's more understandable for the participant. Because again, this is a remote consent process. And it asks them, are you 18 years of age or older, with an easy survey question and branching logic. If they're not, then it tells them, thank you for their interest, they're not eligible. If yes, it asks them, have they had a COVID test? Have they tested positive for COVID in the last 42 days? Next slide. For those that had already been positive, they're not eligible, but for those who had not, have you been tested in the last 42 days? And then the final question is to confirm that the reason that they were testing was because of symptoms. And there is a long list of symptoms. And basically, if they have any of them, if they are testing for any reason related to symptoms, then they are potentially eligible if they met all the other questions. Next slide, please. So the consenting process, as I said, is all online. For adults that are greater than 18, it's on the Hugo-based COVID Inspire website. And there are electronic site-specific consent forms in English and Spanish, because each of our 8 sites has some unique aspects related to that site. It's in a digital format, and based on the site, it's either a signature versus a click-through requirement, but participants are able to do all of that online. Next slide. So the complete enrollment activities, as you can see, are quite intensive. There's the enrolling online, the screening questions, their contact information, the stratification questions and uploading of their lab test, the consent process, and then finally, the more complicated part, which is actually linking their digital health records to the Hugo account. And for this, we have a research assistant actually verify all of these steps to make sure that participants are enrolled and meet the enrollment criteria and are able to continue in the study. Next slide. So the potentially eligible participants sometimes are identified through the electronic review, and their eligibility is verified. They have this Hugo Inspire link, and some of them are actually accessing it individually without any additional encouragement. And in other times, research assistants will actually push them a reminder by text or email, inviting them to come to go through the online enrollment process. And at that point, the same Hugo Health Inspire platform is used to send the baseline survey and follow-up surveys, as well as to access the electronic medical record. Next slide. Here's a screenshot for you of what it looks like on the site for participants. Basically thanks them for their interests and then goes through the series of screening questions regarding age and testing. Next slide. And this is a screenshot of what it would look like when they're at the stage where they're connecting their pharmacy or other digital healthcare portals. And it's really as simple as sharing a logon that allows and acknowledging that you're allowing to share this information for research purposes. Next slide. Here we share with you what our goals are as far as collecting patient-reported outcomes. So at baseline, which is 0 months on this chart, we collect sociodemographic informations. We collect COVID testing information and COVID-like illness symptom assessment. And then we also collect some social determinants of health data. And then every 3 months for the remainder of the study, we continue to ask about COVID-like symptoms. We collect physical and mental health as well as cognitive function data using the PROMIS validated questions. We ask questions about return to work, return to activity, and global health. We ask specific questions about post-infectious sequelae, including dyspnea and cough. And then we do ask about post-traumatic stress disorder using the PTSD-5 and the exercise vital sign. And finally, we ask about the fatigue symptoms using the CDC short symptom screener. Next slide, please. One way that we try to keep participants engaged is with a small incentive for completion of the periodic questionnaire. The timetable is basically $10 every few months and then $25 at the end, with a total of $100 over the course of the study for participants. Next slide. And each site is a bit different in terms of the efforts that they use to encourage participation and continued engagement. In some sites, we're sending reminders via Hugo platform. Actually, everyone's doing that. But in some sites, are sending site-specific emails as well, reaching out to participants by phone or by text or by phone call or by email. We've been sharing newsletters. We have both site research assistants as well as kind of a Hugo concierge that can assist participants with questions about the platform. There are Hugo support team available for technical issues. And basically people are available to assist with study specific questions. That's one way we help keep people engaged. Next slide. And we want to share with you the enrollment progress to date so far. So across our 8 sites, we are as of like a week ago when we were preparing this slide, we were at 2,184 enrolled. Actually, we're up to 2,400 today, so that's exciting. But this slide demonstrates that the distribution of people across the sites based on the color at the bottom and the bars. And we will share these slides with you guys as well. Next slide. As far as the breakdown by age, you can see that we have the majority are quite young, which is not a huge surprise given this is a kind of a low touch digital study. So 54% are between the ages of 18 and 40, though we do have 36% are between the ages of 41 and 64 and 10% that are over the age of 65. We have majority female, 64%. Next slide, please. In terms of ethnicity, 84% identify as not Hispanic, Latin, or Spanish, and 15% identify as Hispanic, Latin, or Spanish. And in terms of race, 64% white, 16% Black or African American, 9% Asian, and some additional races are representative. Next slide, please. And we display for you here some breakdown in terms of the education. So you can see that those reporting that they have a high school graduation or GED are 30%. College degree, 2 or 4 years, are 38%, and more than college is 28%. And the large majority are in English, though we do have 99% participants that identify as speaking Spanish as their primary language. Next slide. And so far, we have 71% of participants in the cohort and 28% negative controls. And just to show you how we're recruiting from the different testing locations, we have 50% are actually from drive-up testing sites, 15% from a clinic, 12% from the emergency department, 14% from the hospital. So really a wide range of recruitment for our participants. Next slide. So that kind of brings you through where we are in terms of what we're trying to do, which is establish cohorts, establish this cohort so then we can go through the data. And one plan that we have is to consider clinical severity in people who have different symptoms at baseline and not. So this is one of the analyses that we have planned. Next slide. So looking at clinical severity, mild versus moderate versus severe, and then a few different things we can assess: those testing positive but without symptoms or with mild symptoms and no functional limitations. Those testing positive and requiring hospitalization but no ICU stay is something we're interested, as well as those testing positive and requiring an ICU stay with or without the need for mechanical ventilation. Next slide. And we have the opportunity to look at the unadjusted and the adjusted incident and risk of outcomes in these cohorts versus the comparator. And this is one thing that we think is unique about the INSPIRE study because it is designed to have the control group. Next slide, and I'm going to hand it back over to Erica to share with you some thoughts about future implications.
Thank you. So we just wanted to kind of circle back, and maybe we could even answer some of these questions that are coming up in the chat about how Inspire, but really a lot of other studies need to inform and transform care as we move forward. Next slide. I wanted to kind of give you some flavor of what we are doing at Yale, although we know about Mount Sinai's clinic, and I can tell you that we've been in touch with many other centers throughout the country who are designed pretty similarly. At Yale, we have the Comprehensive Post-COVID Center at Yale. It's our COVID recovery program that's run out of the pulmonary division. So most of our patients are referred to pulmonary, who starts the evaluation, and then they tend to refer to the specialties that you see here. I can say that one of the biggest specialties that we've been working with is physical therapy. And I can get a little bit more into this, but physical therapy as well as social work have been key team players in our recovery from long COVID. We also receive self-referrals as well as internal referrals from cardiologists. Many cardiologists are not clear about what to do with a person's symptoms, or they get to a point in their workup and they don't know what's happening. Unfortunately, many patients, as you know, are dismissed from the health system because they don't have a diagnosis and they're told that it's in their head. This is a travesty because it's a missed opportunity to help people as well as even to advance science. Next slide. As I mentioned before, our general approach is to exclude disease. We're pretty keen on looking for any lung pathology that is a residual effect of post-COVID. COVID, of course, is a respiratory illness in its primary form. We are, of course, alert to the diagnosis of myocarditis and its different forms as we're seeing it presented. Initially, we were doing a lot of testing for these entities. However, given the multitude of negative tests that came through, we're now really using a much more a Bayesian approach to our diagnosis to better understand what's causing people's symptoms. Next slide. As I mentioned, many of the symptoms are exercise intolerance and excessive tachycardia. People can't exercise. They find it difficult to get back into their regular routine. This includes athletes as well as other very well-trained people. There can be chest pain, dyspnea, and palpitations that don't have a cause. And many of these syndromes share features with the physiology of bed rest deconditioning, which actually has a physiological pathway. It shares features with POTS, postural orthostatic tachycardia syndrome. And because of that, it's informing our rehab strategies. So we're rehabilitating people in a very different way than we typically rehabilitate people who just came out of the hospital or who suffered another severe illness. This needs to expand. We know that there's other shared features. I mentioned chronic fatigue syndrome before. We know that there's metabolic dysregulation. We know that there is autonomic dysregulation, but understanding the unifying mechanisms is really unclear. So in my world of cardiovascular medicine, I'm excluding the major cardiovascular pathologies and then really wrestling with this constellation of symptoms to try to understand the physiology and then the treatments. Next slide. Some of the basic science studies and autopsy studies do show that this virus does affect the endothelium. There's endothelial injury, there's inflammation of the endothelium, and there's endothelial dysfunction. The endothelium is the lining of the blood vessels, and that endothelium is a very active layer, which leads to relaxation, it leads to constriction, and we can see that there's a lot of pathology in the endothelium, which means that it can be affecting blood flow and oxygen uptake. And so because of this, this is an untapped area of investigation, both diagnostically and treatment-wise, that I think we will be seeing more around in the future. Next slide. So we need more randomized controlled trials at all stages of inquiry. And what do I mean by that? I mean, including how best to diagnose these different conditions, and then of course, how best to treat them. We need randomized controlled trials to understand what works, what doesn't. We need to better phenotype people. This is a really heterogeneous disorder. I'm speaking to you as a cardiologist, and I'm sprinkling my cardiovascular lens throughout this presentation. But if this was being given by a neurologist, they'd be talking about the brain fog and the neurocognitive decline that they've seen in people. If this was given by a dermatologist, they talked to you about the rashes that they've seen and other skin paresthesias. So we need to do, and these don't isolate in one person. I mean, there's a constellation of symptoms. So we need to better phenotype people so that when we enroll them in studies, we can enroll like cohorts to figure out what works for this particular phenotype. And then we need to adapt our systems. You know, our systems really need to rapidly evolve in a very multidisciplinary way so that we can triage symptoms and then effectively get people on the road to recovery consistent with where the evidence is for what is best practice. Next slide. So with that, I know that some additional questions appeared on the chat, but we'd like to leave some time for any additional questions that you may have regarding these studies. And we're so grateful for this opportunity to share with you what we are doing, what we know, and look forward to the Q&A.
Erica and Kelly, thank you so much for this presentation. There are a number of questions in the chat that I'm going to turn to in a second. One of the reasons I was so delighted that you guys were willing to present the INSPIRE study as part of the CERSI lecture series is because the Hugo platform that you're using to enroll patients and follow them over time is a platform that we're using for some CERSI related projects. And it offers so many just interesting data sources being pulled together in a way that sort of minimizes the burden on patients, but allows you fairly unique insights. You guys have talked a lot about characterizing long COVID and the syndrome, but by linking to the medical records, I'm curious what you guys are thinking in terms of being able to look at how patients have been treated or treated themselves. I'm sure that's of interest to folks here at the FDA, along with diagnostic tests and how these patients are being tested repeatedly and what's happening. And maybe you guys could just start by speaking to that a little bit.
Sure, I'm happy to speak to that. We are the analytic core at Yale, and so we are using the data that we're getting, not just from the patient-reported surveys, but actually the clinical data from the electronic health records. So there are challenges in identifying standardized definitions, and we do utilize other standards to apply so that we can define what does it mean to have kidney disease or renal dysfunction. One of the things that we know and that we are seeing in the data are that people's circumstances are changing, they're evolving throughout the life of this project. So initially they enroll in our study as a COVID negative person, and then subsequent to that, they are positive. And then subsequent to that, they get a vaccination. And I know there's a lot of questions about vaccination here. So we are pivoting very quickly to adapt to the changing nature of how we see our subjects, because they are not fixed in time. Their enrollment data is not fixed. And because this is an 18-month study, we really need to find where are those inflection points and how is that influencing their quality of life. So we do that by verifying with the medical record. That's an important part because we know that self-reporting is limited. It's not always as reliable to know what a person's COVID status is, what their vaccination status is, when that happened in the timeline, and how that may influence the trajectory of symptoms and clinical outcomes.
Thanks, Erica. Kelly, maybe you want to jump in and just address the vaccination issue. I know there have been a couple of questions about vaccine and whether the long COVID that's been observed is better or worse among patients who are infected after vaccination?
Yes, we're certainly interested in that question, and we'll look at the data to see that. We are collecting information on vaccination status, and people are eligible to participate whether they're vaccinated or not. But we don't have that outcome data yet, but it is something that we will look at.
There was a question on whether your studies are being powered to examine potential racial and ethnic differences in susceptibility to long COVID.
Erica, you want to speak to that?
Sure. We are aiming for a diverse sample. We've been working with community leaders, liaisons to ensure that we have representative enrollment in the in this study, specifically because we think that there could be health inequities either in the clinical outcomes, in healthcare utilization, who's getting care for post-COVID conditions. We're also doing a really thorough survey of some of the social determinants of health that we can also influence people's trajectory. The other thing that we're really interested in is in this negative group, right? So we're living through a pandemic, we're living through social isolation, we're living through unemployment, joblessness, and we anticipate seeing the effects of that in our negative group. So disentangling what is secondary to COVID versus what is secondary to, the circumstances and environment in which we're living under, and which is disproportionately impacting communities of color, low-income communities, will be interesting to try to tease out in our data.
Yeah, that's very interesting. And that's also come up a couple of times in the chat, both with respect to whether there's parallel symptoms on people with influenza to compare to, or how to, people who feel like they've developed symptoms but have never tested positive. Maybe you could say a little bit more about the negative control group. I feel like I kind of missed that when you were presenting.
So we're enrolling people at the time of testing, and we require that they have at least one symptom for which they are testing. So we're not including people who are in some kind of active surveillance program or who are being screened for COVID, let's say, for example, prior to a procedure. As part of the inclusion criteria, those people need to demonstrate that their COVID results. So we actually verify their results, and we're hoping that in doing this approach, we can further match positives with negatives who are similar. So if we're enrolling people from a hospital, we'll be comparing the COVID positives to the COVID negatives. Similarly, as an outpatient, we can also look at age strata, severity of the initial COVID illness, and how that impacts trajectories.
That's great. There was a couple questions in the chat around the criterion, the length of last COVID screening and the diagnostic test within 42 days. How was that established? And a couple of people asked about that. So
it was initially designed to be 28, and really that was so that we were trying to grab people that had an acute illness that made them test. And that was partly just trying to get a similar cohort in the negatives and the positives. It got extended to 42 because we were really buying ourselves more time to help people get the difficult step, which is portal connection. And so it was actually helping us with enrollment more than scientific justification.
Got it.
Yeah, but still we felt it matched the acute, still acute. Go ahead, Erica, sorry.
Yeah, no, these are issues with, recall bias that we were trying to balance and try to find that sweet spot where we felt like we would get an accurate account of symptoms, but still allow people the time necessary to enroll in the study.
Another question came in around retention and attrition, and whether you're finding that varies by COVID status or other characteristics. Your rate of enrollment is fantastic. Hopefully, everyone's sticking around and answering all their questions.
I don't have that available off the top of my head, but we certainly have it, and we receive weekly data at site-specific level about how we're doing and how many of our participants have completed their 3-month survey, 6-month survey, 9-month survey. I know at University of Washington we're doing quite well. I think high, between 70 and 85, 90%. But our team uses that data too to kind of, I want to say compete against site, but try to do better, and also to see who we're missing and how we can re-engage them. I will say that I think it seems a little bit easier to keep the people who have tested positive engaged, and it is a bit trickier to keep the COVID negative people engaged, but they still are for the most part.
Maybe I'll ask one more question so that we can end 5 minutes to the hour, as opposed to running right up to the direct hour. But there was one great question I thought around others social determinant factors that are being collected, including the issue of reliable access to healthcare. Because even though all of these individuals are being identified through healthcare systems, that doesn't mean their access to care is reliable or that there aren't other barriers. So maybe you could speak to that, or what other questions you're asking about it that will allow you to disentangle some of these issues.
Oh, these were big debates that Erica and I had as we were finalizing what questions we were going to put into our very limited amount of questions that we got to ask everyone. One of our main access to care questions is really about healthcare coverage. We ask people about their insurance status and ask them to select all that they have in terms of Medicare, Medicaid, Indian Health Service, military, private, commercial. And that's obviously a proxy that doesn't meet a lot of nuances about real access to care, but it is one of our main access to care questions.
Yeah, we primarily relied on the Accountable Health Communities, CMS, Social Determinants of Health Survey to capture information around housing stability, food insecurity, making ends meet, being able to get to your visits and afford your healthcare costs, but we didn't really tap specifically into the detailed questions around access to regular usual care provider, some of the traditional questions that these were just some of the decisions that we needed to make to limit the survey length. Yeah. That's
very understandable. Dr. Spatz and O'Laughlin, thank you so much for presenting on behalf of the INSPIRE project. For those of you at the FDA who are interested in receiving a copy of the slides, they've agreed to share them. Please just send an email to Latoya Richardson and she'll send them to you, I presume in a PDF format, or else they'll probably be too large. But thank you again. I'm sure they'd both be happy to receive questions over email. And I sincerely appreciate you guys being willing to take an hour out of your day to present. So thank you.
Thank you for the opportunity.
Great, thank you.
Okay, have a nice day, everyone.